As we go through the part 2 of the heart PowerPoint, you are going to want to make sure that you have your heart picture. I am not going to use the one that I used for part 1 because there are so many different labels on it that I actually created a new one that's just going to have the conducting system on it. So if you do have a yellow pen or yellow pencil, you'll want to use that so that you can draw in the conducting system onto your heart. So let me share my screen with you so that we can get to the PowerPoint. Okay, so today the big key thing we're going to be talking about is the action potential within the heart. We'll be talking about the conducting system. So really what you want to think about or what you want to circle on this particular slide is electrical impulse. That's going to be the key that we're going to go through the part 2 of this PowerPoint, is understanding how does the heart actually conduct electricity through the different structures. And then that electricity enables the mechanical events of contraction to actually occur. We'll see how that works, as well as how you can graph that on the ECG, the electrocardiogram, to determine if those electrical events are actually working appropriately like they should. So each heartbeat is going to begin with an action potential that's going to be generated by the pacemaker cells of this system that we're going to be talking about today. And we'll see how other systems are going to help move this signal to other parts of the heart and then move it into the contractile cells so that they can actually create the force of contraction so that the heart can pump the blood around the different structures within the heart and then also to the body. So get your yellow ready and we're going to dive right in. So when we say heartbeat, what we're talking about is a single cardiac contraction. All of the heart chambers are going to contract in series. So first the atria and then the ventricle. Now with your picture, you have already labeled the atria as well as the ventricles. You know, the atria are near the base and then the ventricles are going to be near the apex. So this is going to be in a very coordinated fashion, and there is a lot of very specific events that are going to have to occur within a time frame in order for this to all work out appropriately. When we're looking at the types of cardiac muscle cells, I want you to make sure that you circle auto in the word autorhythmic, so that way you can remember that these cells have the ability to control and coordinate the heartbeat without any stimulation either from the nervous system or from the endocrine system. So they can automatically do this all by themselves. They don't need an additional input supply in order to tell them when and how fast to beat. Now, the nervous system can modulate the heartbeat and it can change the rate, but it's not going to be responsible for the actual production of, due to the fact that these cells within the conducting system have autorhythmicity. So we've got two types of autorhythmic cells. We have the pacemaker cells, and then we also have the conducting cells. As the name sounds like it actually implies, the pacemaker cells are going to set the pace. So it will set the rhythm for the heart. And the conducting cells are going to help move that electrical impulse to different parts of the heart. Whenever you look at the word contractile, keep in mind that the contractile cells are the ones, as the name implies, that will produce contractions. And this is actually the cell type that you learned about in 2401 whenever we went through the different types of muscles, the cardiac, the smooth, the skeletal muscle. When you looked at cardiac muscle, you saw the intercalated disc and you knew that that was one of the things that separated it from other types of muscles. So the contractile cells are what you're already familiar with, but you're not necessarily familiar with the autorhythmic cells. So that's what we're going to talk about first, so that way you can really understand how those cells actually work. We have different pacemaker cells that I want you to label on your picture. So get your picture, and what you can see is in the superior aspect of the right atrium, I have the first one labeled there. That is going to be the SA node. The SA node is known as the pacemaker of the heart. It is going to be in the superior aspect of the right atrium near the superior vena cava. So that's why you want to draw that onto your picture and label it SA node, and then make a little note to yourself. It is the pacemaker. The AV node is going to be a little bit inferior to that, so you're still in the right atrium. You're just going to drop down a little bit closer to that AV valve and put that AV node on there, and then label it appropriately. Between the SA and the AV node, between those, you will have these things that are called internodal pathways. So the internodal pathways are going to be, as the name implies, in between the two nodes, between the SA node and the AV node. What you can see I did on my picture was I just drew some little dashed lines running across the right atrium and then also over here to the left atrium, because the internodal pathways are going to stimulate both atria at the same time. So you want to make sure that you know your internodal pathways are not just going to be specifically for the right atrium, it's going to be for both right and left. That is going to be in between SA and AV, so therefore that will make it the second portion, and that's why it has a number 2 next to it on my picture. After the AV node, then we're going to go through the AV bundle, the bundle branches, and the Purkinje fibers, but I'm going to go to a picture so that way you can get a little bit better idea of those conducting cells, because as we look at this picture, you will see that it's kind of a little bit hard to establish where to draw the next structure that we need. So what I did on this picture was from the AV node, I just kind of went across the heart near the pulmonary semilunar valve and made a thick line. And that thick line is going to represent the AV bundle. That AV bundle has an AKA. This is known as the bundle of His, H-I-S. So the bundle of His is going to transmit the signal and be able to move things from the atria down towards the ventricles. So whenever we look at the cardiac skeleton, we know there's a separation between the atria and the ventricles, but this is going to help allow the passage of that electrical signal to get from the superior aspect of the heart, go down towards the inferior aspect or towards those ventricles. So the bundle of His, or the AV bundle, very important, make sure you label that. And then what's going to happen is the bundle of His is going to split. Whenever you get into the interventricular septum, it's kind of hard to see that I have 2 lines there, but I have one line that's running down the right side and one line that's running down the left side in the interventricular septum. And you're going to want to label that the right and left bundle branches. The right and left bundle branches are going to go through that septum, but on the right side, it's also going to go through the moderator band. So that's why you can see on my picture that I also have it running through the moderator band within the right ventricle. Make sure you draw that on your picture as well. And then what you see happening is after we get to the tip or to the apex of the heart, those fibers are going to turn around and go back in a superior direction as Purkinje fibers. So our electrical signal is going to start at the SA node. The action potentials there are going to generate this electrical impulse that's going to spread through the internodal pathways, go into the AV node, go through the AV bundle, aka bundle of His, drop down into the right and left bundle branches, and then come back up to the top of the heart or towards the base of the heart. So we're moving from a superior to inferior to superior direction, okay? So we start at the base, go down to the apex, and then wrap back up towards the base whenever it comes to the electrical conduction through the heart. If you're labeling that with your numbers because you like numbers and that helps you a little bit, the SA node is number 1. We always start with that as the pacemaker of the heart. I have another picture here that will basically give you everything in order from the superior to inferior direction if you're labeling with numbers. So SA node is number 1, internodal pathways number 2, AV node number 3, AV bundle number 4, bundle branches number 5, Purkinje fibers number 6. So you've got these 6 steps that the electricity has to go through in order to make sure that it is conducting these impulses all the way through the entire heart, and then those impulses will be pushed over to stimulate the contractile cells so that they can contract in order to push blood into the appropriate place at the appropriate time. Okay, so I used orange for mine, but I hope you used yellow for yours. The reason why I'm saying yellow is because Whenever you are in the lab, you will most likely see models that are going to be in yellow whenever they are referencing the conducting system. So that's why I want you to be able to kind of have those colors coordinate in both lecture and lab. So if we are saying action potential, you know from 2401 that action potentials come with a depolarization and a repolarization phase. So if you need a little refresher and a reminder of what is depolarization and repolarization, there is your little graph right there from something that we learned last semester. Now do take note that this is for a neuron. The graph that I'm showing you is for a neuron. Remember, we learned that the neuron has negative 70 millivolts for its resting membrane potential. And then it has to hit the threshold at negative 55 millivolts in order for there to be the action potential. Remember, the action potential is the all or none phenomenon. And it has the depolarization, which means the membrane potential moves in a more positive direction, and then repolarization, which means it moves back to that negative direction. So what you want to put on your picture next to the SA node where you also wrote pacemaker, you want to put a little note to yourself there that this is going to have a spontaneous depolarization. This is different from the neuron. So the spontaneous depolarization at the SA node means that we can get 60 to 100 action potentials per minute, or at the AV node, we can get 40 to 60 action potentials per minute. The AV node can also spontaneously depolarize, but because the SA node depolarizes and gets to threshold faster, it's the one that usually sets the tone, which is why we call it the pacemaker of the heart. If the SA node is damaged for any reason, then the AV node does have the capacity to take over. But as you can see, since it beats slower, that means that the heart rate is going to decrease. Now, if both the SA and the AV node are damaged, the Purkinje fibers do have the ability to take over, but they run at a rate of about 20 to 40 action potentials per minute. So the Purkinje fibers are not going to be able to withstand that heart long term in order to keep the body in homeostasis. So if you're wondering if there is 60 to 100 action potentials per minute, why does everybody not have 100 beats per minute on their heart rate? The reason why is because, remember I said the nervous system can modulate that heart rate. So the parasympathetic system is the one that is dominant in normal physiological heartbeat. So therefore, the parasympathetic system is going to slow that heart rate down. We will talk more in depth about that in part 3 of the heart PowerPoint. So for right now, we're not going to go into that particular aspect, but just know that 60 to 100 variable range can be impacted by both the sympathetic and the parasympathetic system, but the parasympathetic system is the one that dominates. Now, when we say pacemaker potential, what we're saying is the membrane of an autorhythmic cell is not stable. It does not rest like what we saw in a neuron. So if you look at this graph here, what you're actually seeing is there's not this long straight line at that negative 70, which represents the resting membrane potential. Instead, what you're seeing is we have this gradual shift, and that's why we say that this is a gradual depolarization of the pacemaker cells. The reason why this happens is because on the pacemaker cells, they have these channels that are called funny channels, and these channels are permeable to both sodium and potassium. So changing ion concentrations can then change what's going on with that membrane potential and can lead to the action potential. So when the sodium comes into the cell, similar to how the sodium came into the neuron, when the sodium comes into the cell, it's obviously going to decrease it, not change it into a negative state, but we're going to go into a more positive state. We're going to move away from the negative and move into the positive, and that is going to lead towards the depolarization. We have to reach a threshold, and in the actual autorhythmic cells, we say that the membrane potential is around negative 60 millivolts, and reaching that threshold is around negative 40 millivolts. So in order to do that, obviously some ions are going to have to move so that we change the membrane charges. As the membrane potential becomes more positive, the funny channels close and calcium channels open. So that's very important because that's new. We did not see that in depolarization aspect of the neuron. So those calcium channels will open. That will help push that membrane towards a more depolarized state. And if that threshold of -40 is reached, then we are going to have that action potential. So whenever the calcium comes in, it really helps move the actual cell into depolarization. And then at the peak of depolarization, what's going to happen is the potassium channels are going to open, and then repolarization is going to occur, very similar to what we learned in the neuron with repolarization with the outflow of potassium out of the cell. Sorry, I needed some water. So this is going to be the graph for an autorhythmic cell. As you can see there, you see that it says that there's a slow depolarization, and this is due to that pacemaker potential. So whenever you're looking at your chart here for your conduction system, keep in mind that we're talking about this SA node and this AV node, and even these Purkinje fibers that are going to look like the graph that you see on your screen. Now, for those of you who like words, this is your word slide. As you go through and look at this picture, it's basically everything that I've already said, but I've got some other pictures and I'm going to break it down for you in a step-by-step process so that you can add any additional notes that you would like to add for the conducting system to your picture. So again, we're going to begin with the SA node. Remember, this does 60 to 100 action potentials per minute. We're going to start near the superior aspect of the right atrium, and remember those internodal pathways are going to help spread the signal to both atria at the same time. So what you see in this next picture is the actual spreading of the electrical impulse. As you look on the right side, as you look over here, what this is showing you is the tracing of an ECG. And we're going to talk about ECG more here in a few slides coming up. But what they're going to do is they're going to pair what's going on within the electrical system of the heart, within the conducting system, with what you would actually see on the ECG graph. So I'll wait to talk more about the ECG whenever we get to those slides, but if you do want to go back and look at how they work at the same time together, then feel free to do that. So we've got the signal spreading across the atria. As the signal is spreading across the atria, this is going to be our atrial depolarization. So what you just saw on that graph, the depolarization event is actually occurring, and it will give us on the ECG tracing this thing called a P wave. Now, once all of the atria have been stimulated, what's going to happen is the signal moves into the AV node, and there's going to be a delay at the AV node. This delay is very important because it's going to allow the atria to completely contract before the ventricles begin their contraction process. The reason why that's important is because you have to think from this picture as you learned about the way that blood flows through the heart. Remember, you have the AV valves that are going to push blood from the atria down into the ventricles. So if these are squeezing and contracting at the same time that these are squeezing and contracting, what's going to happen is you're not going to be able to move the blood through the AV valves. Because if these start squeezing and contracting, these valves are going to close. So we need to completely get the blood out of the atria, get it into the ventricles so that we have our proper flow of blood through the heart. This delay at the AV node will allow that to happen before these AV valves close up due to the increase in pressure from the ventricular depolarization. So the delay is important. Make sure that you know that we have that little delay there. And the other thing about the delay is this is also the time that it takes for the calcium ions to do their contribution to the contraction process. So as we move from the AV node through the bundle, we're going to go down into the bundle branches, into the interventricular septum. Moving into the bundle branches, remember that right side also goes through the moderator band. So this can then cause contraction within those papillary muscles that will apply the tension to the little fibers, the chordae tendineae, that are attached to the valves and attached to the muscles in the endothelial layer of the heart. So it's going to cause those muscles to brace the cusp of the AV valves so that they stay closed once the ventricles are going to go through their contraction process. Again, this is going to be important for valves because, as I stated in part 1, if the valves aren't working appropriately, then you can have regurgitation, which is the backflow of blood, and this can then affect the entire system. So all of these little fine details are important so that the heart can work specifically as it's supposed to, just so that you can get blood all the way down to your big toe. All right, so once the depolarization goes through the interventricular septum, remember it's going to wrap back up in a superior direction. The reason why it's going to go back in the superior direction is because it has to go towards that pulmonary semilunar valve and that aortic semilunar valve. So if we look again at our picture, the stimulus for depolarization went through interventricular septum, and we're wrapping it back up because as we depolarize these ventricles, what we want to do is we want to build up enough pressure to ultimately open up the pulmonary and the aortic semilunar valves so that blood can flow out of the heart and into the vessels. So as you are learning this, because sometimes it can get a little bit confusing with the difference between depolarization and repolarization, think about depolarization as the event that leads to the contraction. They don't happen at exactly the same time. And whenever we talk about contraction in the heart, we're going to use the word systole. Systole, think about systole as a squeezing process. And then diastole is going to be the relaxing process. So systole will squeeze and diastole will relax. After depolarization is going to come the contraction. So systole follows depolarization. And then after the repolarization is going to come the relaxation. So diastole will follow the repolarization. I know that's a lot of terms, and I know that's a lot to keep straight in your head. But what you want to do as you're learning this is maybe think about how the depolarization, the stimulus, is ultimately going to lead to a contraction in a particular part of the heart, and how the repolarization is going to lead to relaxation of the heart. Okay, so if we have any damage to any of these structures, whether it's the SA, the AV, anywhere along that line of numbers 1 through 6 that you have on your picture, we would call these conduction deficits. There's something wrong with the conduction system that's causing a deficient electrical impulse, which can then negatively impact the heartbeat. So as you are going through, keep your terminology maybe written somewhere on your picture so that way you can remember depolarization is going to be leading to systole, and repolarization is going to be leading to diastole. Okay. Now, if we have any issues with our disturbances in heart rhythm, if the heart starts beating too slow, then we would call this bradycardia. This is normally about less than 60 beats per minute. If you are a highly tuned athlete, however, you could have a lower than normal heart rate. And I'll talk more about how age and athletic status changes your heart rate in part 3. So for bradycardia, just remember less than 60 beats per minute. Tachycardia means it's beating way too fast. That is more than 100 beats per minute. An ectopic pacemaker is going to be something that bypasses the conducting system and causes all kinds of rhythm interruptions. So what you want to remember from this, you want to circle the word abnormal cells. These are abnormal cells that are going to generate high rate of action potentials and cause disturbances to our conducting system. Now, the normal maximum heart rate is 230 beats per minute, and that's because of the AV node. So even if the SA node can go faster, the AV node, remember, has that little delay. So you're not going to see anything above 230 beats per minute in a normal heart. This is going to be a pathological condition where either something has gone wrong inside of the heart or somebody is on drugs, things of that nature, okay? So if we're looking at the ECG recording, what we have to do is place electrodes on a patient. This is just one example of how you could place the electrode leads. This is not the only way to do it. There are multiple ways to do it, but you want to place the electrodes on the patient's body so that we can evaluate what's going on inside of the conducting system. When we look at an ECG, please write a little note to yourself that this is only looking at electrical activity within the heart. We're not going to be able to look at any mechanical dysfunction within the heart via an ECG. So an ECG is not a catch-all, catch-everything evaluation. It's just looking at the electrical system or your conducting system that you have in yellow. So make sure you know this slide. This slide is very important because it talks about the big, huge things that you see on an ECG that you want to be aware of. The P wave, as I said earlier, is when the atria are going to depolarize. You'll see a little P wave. The QRS complex is quite large because this is the depolarization of the ventricles. And we know the ventricles are much larger than the atria. So you're going to see a higher area on the graph in the QRS complex. And then the T wave is going to be the repolarization of the ventricles. So you've got depolarization of atria, but you don't have a repolarization of the atria listed on this slide. You have depolarization of ventricles and repolarization of ventricles. So why is there no repolarization of the atria? Write a little note to yourself that this is within the QRS complex, but because the signal isn't as intense as the ventricular depolarization, it does not show up on the graph. So it is hidden within that QRS complex. It is there and it does happen, the repolarization of the atria. You're just not going to be able to see it because that depolarization is such a strong event. There are other things that you can also see on the ECG, such as the PR interval. So this is from the start of the atrial depolarization to the start of ventricular depolarization. The QT interval is how much time is required for the ventricles to undergo a single cycle of depolarization and repolarization, so a single action potential. The reason why this one is important is because this can be disturbed, it can be lengthened by a number of different things. It could be something as simple as an electrolyte imbalance, so an imbalance maybe in potassium and sodium, or it could be something way more severe than that. In Texas, you know, football is important to us, well, sports are important to us, and we have seen incidences where children in middle school, high school, just pass out on the field and die. And it is horrendous to see something like that happen. That sudden cardiac death is what's usually going on whenever we're looking at a player who we thought was healthy and ended up passing away due to these cardiac events. This can sometimes show up on a lengthened QT interval. Now, I will say that it is important to note that sometimes it can show up as an abnormality when in fact there may not be an abnormality. So I will say it's important to maybe get more than one test. If you are going to pull your child out of sports and say you're not allowed to participate anymore, I would get more than one test on different timeframes just to be 100% sure that you're not limiting that child from doing something that they love if there was a false positive reading. The other thing is that it may not always show. So you have to keep in mind too that it may be there, the congenital defect may be there, but not necessarily show up during the ECG. So for that reason, not everybody goes to get tested because it may or may not actually show something that's worth knowing. Now, if there is a history of sudden cardiac death, or you suspect that there is a potential that this child could have an issue with their heart, maybe because there is a lot of heart history or a lot of heart problems in the family history, or if this child has ever lost conscious on a field or on a court or something like that, I would definitely encourage parents to go and get their child evaluated just to be sure, just to be on the safe side, making sure that that isn't something, a nightmare that you would have to live with later on. Now, the little star up in the top corner is for you to write a note to yourself. HRV is what I want you to write up there, HRV. HRV stands for heart rate variability, because as you can see here, this slide talks about time intervals between the different waves. We also have time intervals between the R to the R, so we can measure from R to R and see how much time is elapsing in those particular instances. And that's going to be important. I'll talk about that in just a minute. So HRV up near that slide, up near that star. You can see here the star is there again. You can see that it says 800 milliseconds. That's about how long it will take to go through that heartbeat. So less than a second, of course, 0.8 seconds. But we don't always want them to be exactly 0.8 seconds. So I'll explain that here in just a second. What I want you to do right now is I want you to look at how they have blown up a particular portion of this ECG readout. And you can see here, you can see your little P wave. Remember, this is when your atria depolarize. You can see this very large QRS complex. Remember, this is where your ventricles depolarize and your atria repolarize. And then you can see the T wave where we have the ventricles repolarizing. There's intervals, there's segments. All of the little squares are specific to measurements. There are different types of ECG papers and different types of measurements. So if you're going into that field of cardiology, you will learn a whole lot more about that. So for right now, what I really want you to just focus on is making sure you understand that the P wave is atrial depolarization, QRS, ventricular depolarization and atrial repolarization, and then the T wave is ventricular repolarization. So here's where I'm going to talk about the HRV, the heart rate variability. As you can see in this top picture up here, you have 1 second, 1 second, 1 second, 1 second. And then down at the bottom, you have 0.93, 0.98, 1.2, 1.3. There is going to be heart rate variability either established as low or high, depending upon the time frame difference between each different beat. If it's all the same, then that means there's low variability, okay, not a lot of change. If it's flexible and it changes, then that means there's high variability. And what you really want is high heart rate variability, because this shows an ability to adapt. If you think about something that's very stiff and very rigid and it doesn't bend, if there's pressure or force applied to that thing that is stiff and that does not bend, then it's more likely to break. If you're looking at heart rate variability, the high heart rate variability shows that you're more in a parasympathetic dominant state, and you do have the ability to adapt or to be flexible or to change as things change in your environment. Whereas if you are in a low heart rate variability, you're living more on the sympathetic side of things, highly stressed. You feel like if just one more thing goes wrong, then you're just going to lose all of your marbles and you're just going to go crawl in bed and not get out again. That's low heart rate variability, so low adaptability. And it also has been linked to different cognitive issues, and behavioral disorders, and psychological imbalances. So whenever you're looking at the ECG, this is pretty much the gold standard for heart rate variability. And you can see I put a couple of other pictures on there as well for you to look at, so you can see how the timing is going to change. But it is possible for you to actually see what your own HRV is. If you have a heart rate monitor like the chest strap, then that should be able to tell you your heart rate variability. Those are going to work better than something that you would use on your wrist. They're going to be a little bit more accurate. And then some things like our sleep number has a heart rate variability that it monitors at night whenever we are sleeping. So I have the ability to constantly be looking every single day at what's going on with my heart rate variability. And it's a good indicator that even if I'm trying to be a positive person, if I'm really stressed, I know that there's something else that I need to do other than just positive affirmations as I see my heart rate variability start to drop. So it's just a good way to check and see, am I on the sympathetic dominant side? Am I on the parasympathetic dominant side? And what things can I do to help push myself over into a higher heart rate variability so that I can have a healthier state overall? It could be physical, it could be emotional, it could be nutritional. We have to think about all aspects of the triangle whenever we're looking at heart rate variability. Now, if there is something that's called an arrhythmia, what this means is an irregularity in the normal rhythm or force of the heartbeat. So serious arrhythmias can indicate that there may be some damage somewhere within the heart, or there could be something, again, as simple as any abnormalities in the electrolytes within a person's body. Maybe they're dehydrated and they are not drinking enough water, or they're, sweating off all of their sodium. So we really have to look and see what is showing up on the ECG to determine what kind of arrhythmia is this. If you look here at these pictures, what you'll see on the first one is a premature atrial contraction, or a PAC. So in a PAC, this is just like a momentary, oh, surprise, extra contraction. So you can see that everything kind of looks normal until you get right around here on this portion of the ECG. And this could be something as simple as stress, or caffeine, maybe an energy drink that you should not have drunk, whatever, you get my point. Maybe you should not have consumed that energy drink. If you were tired, maybe you needed to go lay down and take a nap instead of continuing to push and to force yourself to do more and to do more. So PACs aren't something that are super serious if they're just occasional or random, and okay, you know what, I probably am really stressed right now. Sometimes you may feel them and sometimes you may not. But if things start getting worse and we get into something like atrial tachycardia, at this point, now we're looking at a potential for that heart rate to jump to about 180 beats per minute. Remember, tachy means too fast. So the tachycardia, whenever we're having these premature atrial contractions, it's triggering a lot of atrial activity that is not normal. So that's an irregularity. Versus atrial fibrillation, or AFib, as some people call it, can get up to 500 beats per minute. Now, what you'll also see over here, if you look at this, this will say, even though the atria are non-functional, their contribution to ventricular end diastolic volume is so small the condition may go unnoticed in older individuals. We haven't talked about end diastolic volume yet because that's actually in part 3, but you're going to see what end diastolic volume is and the contribution of the blood flow that the atria give to the ventricles. And you will see how that actually works, and you'll understand a little bit more about why AFib is not as big of a deal as something like VFib. So if we look here, this is ventricular fibrillation. Ventricular fibrillation is responsible for cardiac arrest, and it is rapidly fatal. So now if you're looking at this picture, you see that it looks absolutely nothing like a normal ECG printout. If the ventricles quiver too much and they stop pumping the blood to the rest of the body, then obviously it has no oxygen and no nutrients, and it's not going to go well. So atrial fib, not as big of a deal as ventricular fib because of what the ventricles are responsible for doing, which is ultimately giving blood to the rest of the body. We also have premature ventricular contractions and ventricular tachycardia also listed here, just like as we did in the atria as well. And you can very easily see, even if you don't know everything there is to know about an ECG, just by looking at these charts, you can tell there's definitely something wrong there that is not normal. So as long as you can identify what is normal and you know what's going on the normal components of the ECG, then you will be good for this class. All right, so the question, what would asystole look like if we were to look at this on the ECG? Remember, A means without. Systole means contraction. So without contraction, what do you think the ECG printout would show? This is your flat line. So if you watch those medical dramas and you see the beep and there is no more movement on that graph, that flat line, that asystole, is whenever they usually then say time of death, list out the time. So that is your flat line. An AED is an automated external defibrillator. This is the machine that you would put on your body to help shock your heart to try to bring the heart back into a normal sinus rhythm. There are things that can also be planted internally, but the AED is something that people should be aware of and kind of know how to use in case if somebody does fall out around you. If you can get to an AED machine and you can use it to help reset their heart rhythm, then you could have just potentially saved that person's life. All right, so for evaluation, some people go into the doctor and then they realize they have AFib or they have tachycardia. After the doctor has evaluated and they have given you your definitive diagnosis, if there is a question as well, is there anything additional that I can do to help myself other than maybe what the doctor recommended, whether it is a surgical intervention or through medication? Yes, there are things that you can do. So Dr. Axe has a great article on his website that you can go look up about tachycardia, and you will see that as you're reading this article, he's going to use this thing that's called vagal maneuver. A vagal maneuver. So vagal sounds very closely related to a word that you learned last semester. Vagal sounds like Vegas. So vagus, if you remember, is cranial nerve number 10. Let me refresh your memory. Remember cranial nerve number 10, the vagus nerve is that unique cranial nerve because it is the only one that's actually going to extend down into the thoracic and abdominal pelvic cavities. So your vagus nerve is going to help carry that parasympathetic flow to your heart. And remember, parasympathetic slows the heart rate down. So if you have tachycardia, then you can work on increasing your vagal tone with these various vagal maneuvers in order to help yourself. Now, there's a couple of other things that are going to be no's for you. There are some things you're going to have to stay away from if you truly do want to help yourself. These are just a few of the things. There's some things that you can say yes to. So a lot of people are not familiar with carotid artery massage. Obviously, we've talked over and over and over about yoga, meditation, the importance of sleep, decreasing stress levels. So we've been through a lot of those things already, but the carotid artery massage is a new one. So if you know someone who is suffering with tachycardia, that is something that you might want to look up, as well as those other vagal maneuvers. And acupuncture is always a great thing too, especially if you're highly stressed and you don't know how to help yourself control it. And then there's some supplements that I have listed here. These are all great for the heart. I have said before that everybody, every single person should be on omega-3s because of the necessity of every single cell inside of your body requiring omega-3s, but your heart also requires those omega-3s. And the good part about the omega-3s when it comes to the heart, not only will it stimulate the vagus nerve to help decrease the heart rate, it's also going to increase your heart rate variability, which we just learned is incredibly important for overall health. So definitely want to make sure you get your omega-3s. Now, let's talk for a minute about cardiac contractile cells. These are going to form the bulk of the atrial and ventricular wall. So as you can see there, 99% of the heart is going to be made up of these contractile cells. Again, these are the ones that you learned about in 2401 that you looked at underneath the microscope. They will receive the stimulus from the Purkinje fibers so that they know to contract. And we have those intercalated discs that are going to connect these cells together so that there isn't any interference to the signal and everything kind of contracts in a coordinated synchronous beat, okay? They are going to be linked by gap junctions so that the ions can flow through so that we can go from one to the next to the next to the next without there being any impedance to the flow of those ions. Now, whenever I talked about the autorhythmic cells, I said that the pacemaker cells don't have a stable resting membrane potential. Remember, they have that gradual depolarization that starts off at about -60 millivolts as their membrane potential. The contractile cells are different. So put a little star at the bottom so that you can see that the resting membrane potential of the ventricular cell is about -90 millivolts, and then the atrial cell is about -80 millivolts. This graph is not going to look the same as your cells that were autorhythmic cells. So just to recap your brain and refresh your memory, remember this is what your cardiac contractile cell looks like. We've got that one single nucleus. We have those intercalated discs. And whenever we're looking at how the action potentials are going to work in this cell, it's going to be different from these things that you drew in yellow. So what's going to happen in the cardiac contractile cells is you're going to have a rapid depolarization, not a gradual depolarization, a rapid depolarization because of the influx of sodium through the fast sodium channels. And then circle the word plateau. We have this new thing that we have never seen before occurring in these contractile cells. This plateau is going to be due to the influence of calcium on the contraction process. So the extracellular calcium is going to come into the cell through the slow calcium channels. They're going to initiate this contraction, and then it's going to delay, that's the key word, delay repolarization, which keeps it near that 0 millivolts, and it's going to cause an abnormal look on the graph, something that you're not going to be used to, but it's going to be important that you understand that this is what's happening in the cardiac contractile cell due to the calcium. So whenever the calcium comes in, it's also going to trigger the release of calcium from the reserves that are being held in the sarcoplasmic reticulum. That's going to help continue this contraction. And then for the repolarization, it's going to be similar to what we have learned already and in the past, that potassium is going to come out of the cell through these slow potassium channels, which will then lead to the repolarization state. So if we look at a picture of this, what you can see here is number one, this very sharp rise up from -90 to this +30. So this is our depolarization because of the fast sodium channels. And then you can see here our plateau is the second one. So remember, this is due to the calcium. And you can see here also during this time frame, the absolute refractory period is very long. I'm going to talk about that in just a second. And then for the final step, the repolarization, this is due to potassium leaving the cell through those potassium channels. So keep in mind that whenever we're looking at the autorhythmic cell, it has pacemaker potential, it has gradual depolarization, it has a membrane potential around -60 millivolts. This is not the same as what you're looking at right here, okay? Now, for your absolute refractory period and your relative refractory period, remember from last semester we learned absolute refractory period means that during that particular time, the stimulation, regardless of how intense it is not going to create another action potential. And during the relative refractory period, if the stimulation is strong enough, you can get another action potential. What I want you to really see as we compare the skeletal muscle fiber to the cardiac muscle is how big the blue sections are. So if you're looking over at the skeletal muscle, see how tiny this little blue section is versus how large this blue section is in the cardiac muscle. And then you have this pink portion in the skeletal muscle and a larger pink portion in the cardiac muscle. The reason why this is important is because if you look down here, you'll see the action potential in skeletal muscle is about 2 to 5 milliseconds, whereas the action potential in cardiac muscle is 200 to 400 milliseconds. So there is a time difference for the action potential, but there's also a time difference in how long the absolute refractory period lasts, which means it can't be stimulated to get another action potential. So if you look up at the top, in skeletal muscle fibers, the refractory period ends before the peak tension develops, and as a result, twitches can summate and tetanus or severe spasms can occur. In cardiac contractile cells, the absolute refractory period continues until relaxation is underway. So therefore, we cannot have summation, and therefore we cannot have tetanic contractions within the cardiac contractile cell, regardless of the stimulation. So that's very important. I mean, thank goodness that that is the way that it is and the way that it is set up. That extension of that absolute refractory period that will continue until relaxation is underway will prevent those severe spasms within the heart. And this is everything that I already said on that previous slide. This is just for those of you who like the words. Okay, make sure that you can answer these questions. If you cannot answer these questions, I want you to go back and I want you to review again all of the stuff that I've talked about for the past few minutes in regards to the cardiac contractile cell, so that way you can answer these questions as you may see something like that show up on a test. And then again, as I already stated, calcium is incredibly important whenever it comes to cardiac contractions. So when we're looking at the extracellular calcium crossing the plasma membrane during the plateau phase, see that this only provides about 20% of the calcium required for contraction. 20% is not enough. So this is why we need to have that other calcium coming from the sarcoplasmic reticulum so that we can get that full contraction capacity. So whenever we say the extracellular calcium has a direct and indirect effect on the cardiac contraction, that's what we mean. Now, we've already learned through endocrinology that the PTH and the calcitonin will help with regulating the calcium balance within the blood. So you do have that system that's helping to ensure that you're constantly having the appropriate amount of calcium because of its importance in regards to, well, multiple things in the body, but then also especially to your heartbeat. Okay, so again, as I stated from the very beginning, electricity was our key word. And we have to start with the electrical events of the conducting system in order to get the mechanical events of the actual heart contraction. So remember I said systole means that we're contracting. Diastole means that we're relaxing. So highlight that fluids flow from an area of high pressure to an area of low pressure. So whenever we're looking at pressure, because systole means contraction, that means that during times of systole, there's going to be higher pressure. During times of diastole, because this is relaxation, there's going to be lower pressure. So our blood is going to move from areas in the heart from high pressure to low pressure. So as we go through the next few slides and we see what the pressure differences are that are causing this blood to move in a particular direction, just remember it goes from high to low. And we definitely want to make sure that the valves are working appropriately so we have just that one-way flow. I'm going to quickly show this video so that way you can actually see how the cardiac cycle works as a whole unit. And then I do have some pictures after this that will break it down into the individual components if you want to go through and make sure that you understand it piece by piece by piece, all on your own. So let's watch this video.
Welcome to another Anatomy and Physiology Smart Art video, where we guide you through an important piece of art. After watching this video, you should be able to explain the events of the cardiac cycle. Diagrammed here is a single cardiac cycle, which lasts about 800 milliseconds, or 0.8 of a second. Let's begin here at the red arrow labeled start. In this first image of the heart, all 4 heart chambers are relaxed, therefore in diastole, and partially filled with blood. Atrial systole, also known as contraction, begins and completes ventricular filling. Notice, the green arrows show the atria contract, and the black arrows indicate blood flowing into the ventricles. Atrial diastole follows and continues until the next cardiac cycle begins. Ventricular systole now begins, and is a process divided into 2 phases. The first phase, shown in this figure, is isovolumetric contraction. It is called isovolumetric because the volume of blood within the ventricles does not change. During this initial phase, ventricular contraction closes the atrioventricular or AV valves. The second phase is ventricular ejection, when the ventricular pressure finally exceeds the pressure in the arteries, and that pressure increase opens both the aortic and pulmonary semilunar valves. Blood now exits the ventricles and is forced into the aorta and pulmonary trunk. Here, in early ventricular diastole, blood flows backward towards the ventricles as ventricular pressure rapidly drops. This backflow of blood against the semilunar valves causes them to close. At this time, blood is also flowing into the relaxed atria. Notice here, the AV valves are still closed. This phase is called isovolumetric relaxation. Finally, in late ventricular diastole, all chambers are relaxed and filling passively to about 70% of their capacity. To summarize, a single cardiac cycle includes atrial systole, when both atria contract at the same time to complete ventricular filling, followed by ventricular systole. Isovolumetric contraction is the first phase of ventricular systole and causes the AV valves to close, while the second phase is ventricular ejection, which opens the semilunar valves as blood is forced into the arteries. As blood pressure rapidly drops in ventricular diastole, the semilunar valves close and the ventricles begin to fill again as all four chambers of the heart rest and passively fill prior to the next cardiac cycle. So what? Why is it important to understand the events of a normal cardiac cycle? Well, this is crucial to understanding many serious heart conditions. For example, suppose a patient has a myocardial infarction, also known as a heart attack, that has seriously weakened the left ventricle. Left ventricular ejection will decrease, blood flow will back up between the left and right sides of the heart, resulting in congestion in the lungs. The resulting respiratory complications can be life-threatening. And to understand the many congenital defects of the heart, it's important to grasp a normal cardiac cycle, as these cardiac abnormalities interfere with normal blood flow and valve function.
Okay, so on this particular page, what you can see is the entire cycle as one. So you can use this, or you can use it as it is broken down into each individual component. Whenever you go through and you're looking at this, you want to make sure that you understand what valves are open and then what valves are closed during each of those different phases. So if you remember, whenever we went through the blood flow, as you look through the different parts of the heart, you know that the blood is going to move in a particular direction because I taught you that, right? So keep in mind that in order for the blood to flow through specific valves, it's about the pressure that is going to cause those valves to either be opened or to close. So that's very important to make sure that you know during a particular either atrial systole or ventricular systole, you know, okay, this valve is open or this valve is closed in order for the blood to continue to flow. And also keep in mind that even though we learned it as it goes from the right side over to the left side, there's always going to be blood in both sides of the heart, and it is a double pump. So you're not going to have, blood just in one side of the heart at a time. There's always going to be double pump action going on with unoxygenated blood in the right side and oxygenated blood in the left side. Okay. Now, if we're looking at the different phases, you want to make sure that you know that we're looking at atrial systole. No, that means atria contract, atrial diastole, atria relax. Same thing for the ventricles. So that's the other thing that you have to pay attention to is which part of the heart is actually contracting, because that is then going to impact which valves are open, which valves are closed, and where blood is going. Okay. As we look at atrial systole, this is when the atrial contraction is going to begin. So on your heart diagram, what you want to do is maybe put your fingers on the two atria. The atrial contraction is going to begin and our right and our left valves are going to be open. Obviously, if this is contracting, that means it's trying to move blood from here to here. So therefore, these valves need to be open to allow that to happen. So the atria will eject the blood into the ventricles. Now, very, very important, circle this tops off the ventricles because they're already 70% filled from the previous cycle. As you just saw, there's going to be a passive flow of blood into the ventricles. So this contraction from the atria is only going to provide an additional 30% down into the ventricles. This is why whenever we're looking at AFib, it's not necessarily that big of a deal because these ventricles are going to already have 70% of the blood that they need. So an irregularity in the contraction within the atria isn't going to be as terrible as it actually sounds. I know it sounds bad, but because of the passive flow of blood into the ventricles, it's not as deleterious as ventricular fibrillation. Now, when we have atrial systole end, that means that atrial diastole is going to begin. If these are done contracting and then they start relaxing, that's the difference between systole and diastole. You can see here on the slide, it says the ventricles contain the maximum blood volume. So they have contracted, they have given off the 30% that they need to do through their contraction. Now what happens is these ventricles that are down here relaxed. Remember, relax is related to diastole. Those ventricles contain what we call EDV, which is end diastolic volume. The end diastolic volume is about 130 milliliters, or about 4 ounces. That is important because whatever amount of blood is in the ventricles is the amount of blood that you have as a possibility to pump out to other parts of the body. If you've only got 1 ounce within the ventricles, you're going to be in a very big problem. So about 130 mils is our average for our end diastolic volume. Once these ventricles, so put your fingers here now, once they have all of the blood that they're going to get, the EDV, then what's going to happen is the AV valves need to close. And those AV valves will close as the pressure builds up within these ventricles. So as the pressure is building right here, the isovolumetric contraction is going to be within this space because the blood isn't going anywhere yet. These things have closed, the blood is sitting here, the ventricles are building up pressure as they are going to do their contraction, okay? Now, whenever there is enough pressure, there has to be enough pressure that has built here. Remember, we have the Purkinje fibers that are going to wrap back up to the superior aspect of the heart. Once the pressure has built up and this signal is all the way back up towards the base of the heart, and it causes enough pressure for these ventricles to start squeezing, that's going to be enough force to pop open the pulmonary and the aortic semilunar valves. That is then going to lead us to the ventricular ejection, is whenever this pressure exceeds the pressure of the blood within these two vessels. It will pop open those semilunar valves, and now the blood can come out of the heart. When the blood comes out of the heart, we call this stroke volume. So everything that has left the ventricles, we will refer to that as stroke volume, but it's not going to be 100%. That heart, those ventricles are not going to be left without some blood remaining in there. So our stroke volume is a very important thing that we're going to talk about next time in part 3. Then what's going to happen, the semilunar valves, remember they popped open in order for the blood to come out of the heart and get into the vessels. What's going to happen is this pressure right here is going to decrease. And as this pressure falls, then the blood is going to start to flow backwards, and it's going to cause these valves to close. So the force of the blood coming back on them is going to cause the semilunar valves to close off. And whenever they close off, we say now our ventricles contain what's called the ESV, or the end systolic volume, meaning we squeezed, got the blood out of the ventricles, but there's still some that's left in there. That is your end systolic volume. So after the end of the squeezing, what is the volume that is remaining? And that's normally about 40% of what the ventricle started with. Remember, they started with the EDV, and stroke volume should be around 60%. We want stroke volume to be around 60% so that the rest of our body can get oxygenated. Okay, so ESV is what's remaining in here after that contraction of the ventricles has occurred. Now, I want you to use your hands, and I apologize for this tan that's not coming off very good. It is like all over the place and a hot mess. So my hands don't normally look like this. It's tanner from my birthday. What I want you to do is use your hands. Okay, this is going to represent the systole, the squeeze, the contraction. This is going to represent relaxation. So you have contraction, relaxation, contraction, relaxation, systole, diastole, systole, diastole. So what I want you to do is I want you to pretend that your hands are the left and right ventricle. If your hands are relaxed like this in diastole, then let's say we're going to put some red jello in your hands. The red jello that's going to be in your hands, however much red jello you can hold, is going to be the EDV, or our end diastolic volume. So we're in the relaxation, that's diastole. We're going to have red jello in our hands. We're going to call this 130 milliliters of jello our EDV. As your ventricles squeeze, so make your hands fold together in the squeezing motion. As they squeeze, obviously the jello is going to run out of your hands onto the floor, down your arms, maybe even a little bit, and going to hit you in the face. Okay, everything that comes out of your hands is the stroke volume. So this process, systole, leads to stroke volume. We hope that about 60% of the jello has now come out of your hands. Now, you know that even though your hands are closed like this, you still have some jello in your hands. You can feel it in your fingers. You know that it's there. That is your end systolic volume, okay? So EDV, jello everywhere. I don't know what that noise was, sorry. Jello everywhere is your stroke volume. Jello left in the hands, end systolic volume. Okay, so remember it like that. All right, and then whenever we get into the last little bit here for ventricular diastole, obviously after they get finished squeezing, they're going to relax, right? So now we've squeezed, we've got blood out, the pressure has decreased, the blood is flowing backwards, it's closed these two valves. Well, now we are in isovolumetric relaxation. At this point, all of our heart valves are closed in isovolumetric relaxation. The ventricular pressure is higher than the atrial pressure, so the blood cannot flow into the ventricles. Instead, the blood is going to flow into the atria. Blood flowing into the atria is important, obviously, because remember, this is where we're going to have to start this whole process all over again, ultimately, in order to do another heartbeat. So those AV valves are going to eventually open up. So you're going to have the two AV valves open. The ventricles are going to fill passively. Remember, that's about 70% of filling. And then we are going to go through the cycle all over again with that atrial systole causing the top off of the ventricles with the last 30%. Now, in this next sentence, you can see individuals can survive severe atrial damage because remember, it only adds 30% of blood to the ventricles. But if they have ventricular damage, then that can definitely lead to heart failure, because that means you're going to impact the whole body, including the heart. Remember whenever I taught you the flow of blood from the heart, after the blood gets oxygenated and it goes out of the aorta, remember the first place that that healthy oxygenated blood is going to go is back into the myocardium. So it will go through the right and left coronary artery to go back into the myocardium. And if you're not having the ventricle push that blood into the aorta in order for it to get into the RCA and the LCA, you will not be oxygenating this organ, and this organ will fail if it doesn't get the oxygen and the nutrients that it needs. Okay, so that is your cardiac cycle. That is how that is going to work. On this picture here, what you can see, if you look in the book, the next two slides, they're all together on one big picture, but I couldn't get it all on the same slide. So what you're looking at is basically the different phases of the cardiac cycle that we just talked about in regards to pressure. And on this graph, it will also show you where you're going to have your AV valves opening versus where your AV valves are going to be closing. And then on this side, you can also see the same 8 steps that we've already gone through are going to be the same 8 steps that you see on this graph. If you don't like the graph, that's fine. You do not have to use it, but I know different people have different ways that they learn, and so some people may really appreciate and like the graph. So if it works for you, then by all means use it. But if you prefer something else like the video or just looking at your heart, do whatever works best for you to remember what's going on in the cardiac cycle at the different phases. Now, if we were to listen to the heart with the stethoscope, what we can hear are some heart sounds. So S1 is the sound that is going to be made whenever our AV valves close. So put your fingers on your AV valves. S1 is the sound whenever this guy closes, okay? If we're talking about S2, that's going to be our semilunar valves closing. So S1 and S2 are going to make those very typical lub-dub sounds. There are S3 and S4. These are soft sounds. Not a lot of people can hear those sounds if you're not really well versed in listening to the heart with a stethoscope. That's okay. Just know your S1 and your S2, what they represent, and then of course what they sound like. The heart murmur is a sound that is going to be produced whenever you have a problem with the valves that is creating the regurgitation. Remember, we don't want that backflow. We want the one-way flow. And if there's something wrong with the valves, if they have some sort of issue and they're allowing blood to escape and flow backwards, you're going to hear it in the sound of a murmur. That video right there on YouTube is a video that will let you hear what a murmur sounds like. It's kind of like a swishing sound. So if you want to watch the video, feel free. If you don't, that's okay too. You can see here that whenever we are going to auscultate with the stethoscope, you're not going to put the stethoscope in the exact place as the valve location. The reason for that is because the sounds are going to be reverberated through the tissues and the bones in the body. So you don't put it right over the valve location. You put it in a little in a different part. It's close, but not completely over that particular valve. So as you can see, it's going to be in the chest area. It's a lot easier whenever you're learning how to do this to do it on a guy, obviously, because they have a flat surface that you can use. And if the guy is skinny, you could even count his ribs so that you can ensure that you're in the right spot. A little bit more difficult to do with a female, especially if she is heavy chested, but I do recommend that you do practice that because you do need to learn how to use good bedside manner and how to be appropriate with all patients, not just the one that you're used to practicing on. And then this last graph here is just going to combine the pressure graph that I showed you earlier with the heart sound. So you can see here that S1, that lub sound, is responsible whenever the AV valves are closing versus S2 when those semilunar valves are closing. So if you like that graph, then you can use that one as well. All right, so that's all I got for heart part 2. Make sure that you go through that again. If you have any questions about it, then feel free to let me know. Remember, you want to know the differences in the terminology, depolarization, repolarization, systole, diastole, what's going on the ECG, and then what's going on in the cardiac cycle. How is the electrical impulse causing the mechanical events that are going to cause the heart to build pressure in particular areas, and then the valves to close at different points in time in order to move the blood into the different parts of the heart and the body.